to do today is firstly to explain to you basically how IVF works, and then to give you a bit of personal insight that I've obtained throughout the years. Okay, so IVF has been around for 42 years. This is Louise Brown. It's the first baby born through IVF. So 42 years sounds like a long time, but we still have a lot to learn in the realm of fertility. If we look at who should get IVF, there is hard and fast rules. So the hard rules say it's the patient who have blocked tubes, those with severe endometriosis, those with severe male factor like very few sperm, very poor motility or morphology, those who have been trying to fall pregnant for more than 2 years with unexplained infertility. If you look at the NICE guidelines from the UK, they say if you have unexplained infertility after 2 years of trying, you should consider IVF and skip the insemination route all by itself. Those with failed management. And then fertility preservation is for the cancer patients, number one. So if you're diagnosed with cancer and we want to spare some oocytes or some sperm before you get your chemotherapy, we can offer that. And PGD is for patients with severe genetic abnormalities in their families. If they say, I've got polycystic kidney disease, I really don't want a child with this condition, then we can do IVF and select not to transfer the effect to the embryos. Okay, so this is the normal menstrual cycle. In the normal menstrual cycle, this is menstruation. From the beginning of the cycle, your body makes FSH. The FSH is at such a dose that it only selects one follicle to develop, and the rest don't grow as quickly. And then that follicle makes estrogen, which lets your lining increase in thickness. As soon as the follicle is big enough, your body secretes LH, the pituitary gland, which lets it ovulate. And then that follicle makes progesterone, which prepares your lining for implantation. So that's the normal cycle. If we do IVF, we also give FSH, but we give it at a much higher dose so that we can get a lot of follicles to grow. Okay, your lining will thicken. That's how we know that you're responding, because your lining thickens from the estrogen that you are producing. When your follicles are big enough, we give you a trigger shot, which is basically the same as the LH that your brain is making to mature the eggs. And then before you ovulate, we want to retrieve those eggs, which I'll show you in a little bit. Okay, and then we need to add on progesterone, because all the IVF drugs that we are giving you is making your progesterone dip sooner than normal. So we give you progesterone to maintain this lining, and if we don't give you enough, then you will have bleeding. Okay. All right. There are two main protocols that we use for IVF. The most common one is what we call the short protocol, and this all happens over one menstrual cycle. So when you start menstruating, on the third day we'll do an ultrasound. Then we will start giving you medication to stimulate the growth of the ovaries, and once the follicles are big enough, we will add a block. So the aim of the block is to prevent ovulation from happening. We don't want your body to release the eggs. We want to retrieve them via the aspiration. The long protocol happens over 2 menstrual cycles. So this was traditionally the first protocol that they used, but we don't use this anymore as our preferential one. So there we start blocking already in the cycle beforehand, so that all your own hormones go down to very low, and then we start stimulating in the next cycle. So that's a good choice for patients with endometriosis, adenomyosis, or where we see the short protocol does not do them justice. Okay. So the stimulation. The hormones that we give is very similar to the hormones that your body is making, so FSH and LH. There's gonal F. Gonal F is just a FSH, and then the other products like Menopur, Pergoveris, Merional, most of them is a combination of a FS and a LH-like substance. Okay. So when you come on day 3 of your period, we will do an ultrasound, and then we look at your ovaries. So the ovary has little follicles, the antral follicles. We can count them and see what we can expect your body to produce during that cycle. If you have only 3, we're not expecting that you're going to have 20 eggs. Every follicle that you have is what you can produce. Okay, we will also check your lining. So during menstruation, we expect your lining to be very thin. If it's not thin, we must think about other things like polyps. Then you start stimulation, you come back in our clinic on day 9 and day 11 that we assess now. Is your follicles growing? Is your lining thickening? As you can see here, there's quite a good response. We'll measure the size, and then we want those follicles to reach about 18 millimeters to know that we will now retrieve mature eggs from them. And we want to see your lining thicken, but we also don't want to see that it's changing in color, because if it becomes too white and too dense, it's showing us that your progesterone has gone up too early. Okay, so this trigger shot is the one that's going to mature the egg. So normally, in the ovary, the oocyte is bound to the capsule. And as soon as we do the trigger shot, it releases into the inside of the follicle so that we can retrieve it. Okay, so important things about the trigger shot. One is the temperature. So if we use Ovitrol, which is the most common trigger, it needs to be kept cold. If it gets very hot and you leave it in the back of your car, we're not going to get optimal function. Other thing is timing. That is of crucial importance. So if you trigger too early, we might not retrieve eggs. You might ovulate. If you trigger too late, we also might not retrieve eggs. So this is one very important mistake that you should not make. Okay, if the clinic says, please trigger at 8 o'clock, you need to trigger at 8 o'clock. We know that we will retrieve eggs around 36 to 40 hours after the trigger shot. Okay, the other thing to know is if we use Ovitrol, this is the same as the pregnancy hormone. So if you use an Ovitrol trigger and you do a pregnancy test, you should get 2 lines. Okay, so many patients make that mistake and they trigger, and a day after embryo transfer, they're already testing and seeing, are they pregnant or not? So the trigger will show up positive in the beginning. Okay, that doesn't mean you're pregnant. The other thing to know is that you will feel pregnant from the trigger because it is pregnancy hormone. So you will get a little bit of nausea or a metallic taste in your mouth. You can already start having pregnancy symptoms. So we all want to see that positive line, but don't misinterpret it as a positive too early. Okay, then the aspiration procedure. So clinics do it differently. At our clinic, we do it under conscious sedation. So you get an IV line. You are not awake for that few minutes. We clean the vagina, and then we use an ultrasound, the transvaginal probe, with a guide to show where the follicles are, and we insert the needle and aspirate that fluid into a tube. And that tube we give the embryologist. What you can expect to feel with aspiration is you're going to feel bloated. You will have some stabbing pains. Some vaginal bleeding is to be expected. So the day of aspiration is not one that you should plan a lot of vigorous activity. Rather, better to go rest. Okay. Then this is the hard part for the husbands. Oh, my word. I think they are more stressed about their contribution to the cycle than the females are. So, in terms of the sperm for the husbands, abstinence 3 days beforehand is a good idea. Remember, if you are doing IVF and you have intercourse earlier, it's probably also a good idea to use condoms then, because we don't want you releasing a few eggs and us putting a few embryos and you end up with more babies than we plan. Okay. Then, if you stay close to your clinic and you are really worried about the emotional part, psychological part of producing the sperm, you can arrange with them to produce it at home and bring it in. Okay. It's far better doing it that way than standing with a red face at the clinic and saying, I'm sorry, but I can't. Okay. We can also arrange for a special condom, and this is a latex-free, lubricant-free condom that you can use, have intercourse with, remove the condom, fold it, and put it in the little bottle. So there are options. It's important to speak to your husband beforehand and make sure that he's going to be okay. If he's not, you can always freeze sperm beforehand, because you don't want the stress of having gone through an egg retrieval and then no sperm. We don't want to have intercourse directly after an egg retrieval. So rather prepare for this psychologically and physically, that we know that we've got good sperm on the day of aspiration. Okay, so now the embryologist has those tubes, and then they have to decide whether they are going to do IVF, which is the normal in vitro fertilization, or ICSI, which is intracytoplasmic sperm injection. So with IVF, it means we are going to take the eggs and the sperm, put them together and say, do your job. We are not interfering. If you do that, we have to make sure there's good enough sperm, so the sperm amount should be good, they should be very motile, and we shouldn't have any queries whether they're going to be able to fertilize the eggs. If you do ICSI, it means you are going to clean off all the granulosa cells around the egg, and then we are going to make sure it's fertile or mature, meaning there's a polar body, and we catch one good-looking swimming sperm and inject it inside the egg. So that we do because we don't want fertilization failure. We don't want to say the next day, I'm so sorry, but nothing is fertilized. Then the whole cycle is down the drain. So many clinics will do ICSI or ICSI and IVF combination. Okay. The embryologist, this is important to understand. If they tell you you've got 10 eggs, it doesn't mean that all 10 are mature. So the eggs can be very immature, meiosis 1 or meiosis 2. So this is a mature egg that has the ability to fertilize. The other egg still has to undergo maturation to obtain the ability to fertilize. Okay, so in the lab you can do in vitro maturation, where we leave the eggs and see if they mature and then fertilize them on the next day. Okay. Then when we look at the embryos, so an egg that has fertilized on day 1 under the microscope will have 2 pronuclei, 2 polar bodies. Then we know this egg is now fertilized. Then within 12 hours it will start dividing into 2 cells, 4 cells, 8 cells. On day 4, those cells start merging together to form a morula or a compacting embryo, and then it forms a blastocyst. Okay. So most of the time, if you've got many embryos, we want to transfer a blastocyst because we can see on the quality of the embryo what is the best to transfer. Okay, so a blastocyst has got an outer cell layer or trophectoderm, an inner cell mass that forms the baby. We can give you a quality grading on that and then select the best embryos. If you have only 2 embryos, we transfer on day 3 because we think that the uterus is a better incubator than the laboratory. But you can also elect to wait and see if they blastulate and then transfer them. Okay. Just briefly want to explain to you how PGT or pre-implantation genetic testing is done. Some clinics advise all their patients to do PGT. Other clinics might say it's not worth it. Okay, so PGT is when you get a blastocyst. You can also do it on a day 3 embryo, but a blastocyst, you're going to make a hole in the outer membrane with a laser and biopsy, suck some cells into a pipette and cut them off. Then you're going to send those cells for genetic analysis to count the chromosomes and see if it is chromosomally normal. Okay. When you do this, we know that it will decrease the miscarriage rate. If you have a lot of embryos, it might make the time to pregnancy faster. So instead of taking 6 months, it might take 3 months or 2 months. Okay, but it does not improve your live birth rate. So if one patient does PGT and the other one doesn't do PGT, at the end of their treatment, they will still have the same amount of babies that they would have had at the beginning. Okay. If you do this, it doubles your cycle cost because you need to pay for the biopsy and the freezing and the genetic analysis and then wait another cycle for the results before you put back. And the difficult question is, what are you going to do if all your embryos come back abnormal? Because abnormal is also a range. It can be completely abnormal or a little bit abnormal, which we call mosaic. So we don't know. We see that there has been normal babies born from mosaic embryos. So in our clinic, we don't advise patients to do PGT because we think that it is better in our minds to rather do 2 cycles. It will give you a higher chance of pregnancy than doing 1 cycle with PGT. But of course, it is individualized. Okay, so after the trigger shot and the aspiration, we need to start progesterone. So progesterone in an IVF cycle is a must because I explained your natural progesterone dips quicker, and we must supplement to keep your lining. So there are various ways. There's crinone, utrogestin, cyclogest, dufaston, all kinds of injectables like Plaris and Gestone. And most of the time, progesterone is not nice to take. I can tell you from a personal opinion, it makes you feel tired, bloated, constipated. The vaginal forms, amen. Yeah, so crinone is good, but it gives you a very thick white discharge that takes long to go away. Important from crinone, in my experience, is it builds up. So it's important not to just pop a new crinone every day because it builds up, and then the absorption is going down. So if you use crinone, scoop out the old ones before you put the next dose. I've seen a patient at 24 weeks of pregnancy with a ball of crinone this size coming from her vagina and bleeding. Just to show you, it really builds up. Okay. The cyclogest and utrogestin. The utrogestin is nut-based. I've seen bad allergic reactions to it, so make sure you're not allergic to nuts before you take it. The cyclogest gives you a horrible fatty discharge. You can pop it rectally as well, for those who don't like it vaginally. Just make sure you don't pass stools within 40 minutes. Okay, embryo transfer. So embryo transfer we want to do with a full bladder. Make sure you go to your clinic with a full bladder. Most of us do it ultrasound guided, so we hold the ultrasound probe that we can see your uterus, and then we use a very small catheter to deposit the embryo into the endometrial cavity. When you do embryo transfer, that's also the day that the embryologist will tell you whether you've got embryos left over to freeze or not. Okay. So this is the personalized spin that I can put on this. I've done 2 IVF cycles myself. We struggled for 6 years to get pregnant. My first cycle, I got a pair of twins. And my husband said, "Thank you very much, that's it, never again." Took us 3 years to recover emotionally, financially, physically, spiritually from having the twins. They were a big blessing. But oh my word, not easy. And then after 6 years, he said, "Okay, maybe once more." So we've got another little one who's 7 months old. So what I wish to tell you for the future. When you do IVF, please don't tell everybody that you know, including, don't Facebook it, Instagram it, Twitter it. Preferably don't tell your family or the grandparents, because whenever they know you're undergoing treatment, they already see the baby. Okay, so keep it quiet. Maybe tell one trusted friend that's going to pray with you and support you and not want to badger you the whole time about how it's going. Okay. Second one is don't count your chickens before they hatch. Not every follicle that you see, not every egg that we retrieve is going to give you a baby. Okay? I so many times see it that people get excited, and it's good to get excited, but we need to stay realistic as well. Even if you see that 2 stripes on the pregnancy test, it doesn't mean we're going to take home a baby. My husband, I almost killed him because with my positive pregnancy test, with my IVF, he put it on Facebook. And I got congratulation notes from my patients and my friends saying congratulations. I was like, but okay, so don't go there, not yet. Those eggs have got hurdles to come over. So not every follicle that you will see will give us an egg. Not every egg that you see will be mature. Not everyone will fertilize. Not all of them will blastulate. And not everyone will implant. And even when you have a pregnancy test, not every positive pregnancy test gives us a baby. So it's important just to know that. Okay. This is a graph, it's an old one, but just to explain to you, if you get 10 eggs, 8 of them are mature, 6 fertilizers, 4 goes to day 3, 2 goes to day 5, and then about 1 gives us a baby. Okay, this is just to explain to you, 10 eggs doesn't equal 10 babies. Okay, then don't compare yourself to others. I know there's a lot of Facebook groups and support forums, and it's so easy to go and see what people has gone through and say, but she got a baby from 1 egg at 47, so that must be me. That is not the story for everybody. So when you go through your IVF, rather stay off those groups, stay focused, stay optimistic, but don't compare yourself. And then don't worry about things that you don't have control over. You can only do your part. You don't have any control over how your body is responding, whether the embryos are growing, whether they are implanting. You do have control over these things, about what you eat, about what we weigh, whether you're smoking, consuming alcohol, whether you're mentally well, the medication you take. So if you are doing these things, you are doing all that you can. Okay. It is normal to feel frustrated, angry, emotional. Warn your partner. It's not just the emotional stress of the cycle, it's the hormones as well as not your friend. So I always say to my patients, warn your husband, flowers, chocolates, and don't say a word. So like Dory says, we must not lose hope. We must just keep on swimming. Even if we feel angry and we don't always find Dory, we know, and don't worry if you take it out on us, we know exactly where it's coming from. It is normal to feel as if you are grieving when you struggle with infertility. I can remember the days before we did our IVF that I would cry when I get my period. And when my people, like my sister or my family, said that they were pregnant, I would be happy for them, but secretly cry out to God and say, but God, why? This is so unfair. Why is this happening to them and not me? It's normal to go through a grief response. And if you know the stages of grieving, I'm sure all of you will be familiar with the anger and the depression. The quicker we come to accept that our IVF cycle can go either way, the better you will be off mentally. So to me, I said to myself, if it's a negative, what will I do? Is it the end of the world? No. Is there still hope? Yes. So when you can accept that reality before you begin, you're in such a better place emotionally. And then remember that the men don't always talk, but they feel just as bad. They might feel incompetent. The strain of this, whether it's emotionally, financially, they feel just as badly as we do. So remember not to lose your partner in the path to parenthood. Be good to each other. Make sure you're building on a solid foundation, because I can promise you, raising kids is next level. Okay. If you do then face the failure, remember we learn something from it. Everybody's body is different. We can apply the same protocols, people will respond differently. And we learn something in the process and we say, but listen, this protocol doesn't work for this lady, or she ovulates early, or we learn something from it. So failure is not the end of it. It's just a stepping stone. So as long as you don't quit, there's hope. Thank you.
Good afternoon. Thanks for having us. I would just want to understand what is the causes for the follicles to stop to grow? Because we had 5 failed cycles last year, and the same problem, and we still don't know what is the cause. Maybe there's something that we could have done better, or prevented, or something.
Okay. Can I just ask, how big were they when they stopped growing?
The latest failed one that we had in January, it was, I think, 13.
13 millimeters.
Yes, and the other 2 was 8, and just they stopped.
Did you ever retrieve?
We retrieved last year, and on the retrieval day, there was nothing. There was the orange like liquid or black like, yeah, but this.
Okay, so that's not common under the IVF population. Okay, sometimes you have to carry on longer. Sometimes you need to up your dose. Okay, sometimes you need to tailor the medication that you give. So I've seen, for instance, some patients do very well on letrozole if you give them a high dose of that. Okay, not everybody's follicles will go to 20. Sometimes, for instance, PCOS patients, because the ovary is so hard, they don't grow bigger. Okay, it can be, and I cannot promise you that a next cycle will go better. Sometimes there's a genetic problem with the maturation or the enzymes inside the follicle. Okay. So complex question, thank you.
It's surprising that you'd say it's not common because personally I also had empty follicles. So the question really, it was really a good question. And so I'm still yet to understand what is it really that causes empty follicles? What is it that one can do besides just eating healthy, exercising, not smoking?
So empty follicle syndrome is a different entity now. Okay, so on her side, she said they arrested at a certain stage. If you now have these big follicles and when you do a retrieval, you don't get any eggs. If it happened one cycle, it could be a trigger thing. So if you only triggered, for instance, with Ovitrel, you can add a leucine trigger or a double trigger and just see, because it could be that your oocytes are not releasing soon enough or the trigger dose is not good enough for you. Okay, so from one cycle, it's not that common. Okay, if it happens repetitively, then it might be an individual thing.
I've had 3 IVF attempts, and unfortunately, all 3 was not successful. But my question is, after the 3rd attempt, my menstrual cycle is not normal, is very weak. Could the medication have affected my menstrual cycle, or what could cause that? And is there medication that I could take to correct that?
Okay, so after a cycle, people usually have quite a heavy bleeding. Okay, and it can throw out your cycle for a month or 2. But thereafter, if it is very light or it's different in pattern, you rather need to go investigate why. Okay. Whether it's hormonal, whether your ovaries have got enough eggs, is your thyroid okay, your sugar okay, your prolactin, to make sure that there's no hormonal reason for the cycle to be very weak.
Cool. Just one question after this lovely lady.
Ek wil net weet na implanting, wat is die mediese rede is hoekom dit nie vat noodwendig nie?
Okay, so she asks, when you've transferred embryos, why don't you get a pregnancy? Okay, so it's a good question and it's important to understand. Okay, so when implantation depends on 3 things. 1 is the embryo, 2 is your endometrium, and 3 is your external environment. Okay. So if we transfer 2 embryos or even 1 embryo for a young person, say below 30, 50% will implant. So 1 will implant, 1 won't implant. If we transfer an embryo, say for a 40-year-old, we need to transfer for 10 people at the age of 40 to get 1 pregnancy. Because age is a big indicator of your egg quality and the quality of the embryos. So that is one big thing. You know, you need to see how old you are and go look at the statistics for your age to see what is your chance of pregnancy. So abnormal embryos is one thing. abnormal embryos will either not implant or they will implant and miscarry. And that is nature's way of protecting you from having a severely disabled child. Okay, the endometrium, after one transfer, we cannot call that recurrent implantation failure. If you've had 3 transfers of very good quality embryos, then we need to go look at your endometrium, whether it's receptive, whether the window is open at the appropriate time, whether there's inflammation. And then the external factors are like thyroid, diabetes, clotting abnormalities. So if people have had recurrent failures and we've investigated the other causes, those are also things that we need to go have a look at.